dear friends. So I welcome you all to this webinar on all about ACL injuries. So we all sports injuries specialists, we come across these most common injury in our day-to-day practice. So that is the reason we have taken out this topic. We have a very good faculty today, Dr. Kumar, Gaurav, who has done his graduation, post-graduation from Patna Medical College and has done several national and international fellowships, and he is practicing in Patna in his Scopy and Joint Clinic. So he will talk on why does an ACL fail, and then we have a senior consultant and head of the unit of joint and sports injury at Meenakshi Mission Research Center, Madurai, Dr. Vassan. So sir will be speaking on anterolateral bundle reconstruction. Then I, Dr. Prahalad Singhi, who is a consultant unit chief of arthroscopy and trauma unit at Preeti Hospital, Madurai. So I will be talking on primary ACL repair. We were supposed to have Dr. Yogesh, who is not able to join because of certain reasons. So I will just briefly run a video on ACL avulsion injury. So I asked Dr. Kumar Gaurav to start his presentation.
Thank you, sir. Thank you so much for giving me a chance to present it.
Yeah, I also thank Biotek for organizing this webinar.
Yeah.
So any audience, if they have any questions or queries, please use Q&A box to ask the questions.
Are you getting, sir?
Yeah.
Yes. Hello, friends.
I am Dr. Slideshow.
Yeah. I am Dr. Kumar Gaurav. I am practicing at Patna Joint and Sports Injury Clinic. I started the topic of why ACL reconstruction fail. First of all, I'd like to thank Dr. Singhi and Dr. Vassan for giving me the opportunity and for the webinar, and I'd like to thank Biotek people also for this webinar. Now, my topic is why ACL reconstruction fails. Why ACL reconstruction fails? ACL reconstruction fails. First of all, I like to say that we are doing
ACL. Sorry to interrupt. Can you do slideshow? It is.
Yes, sir. I'll be changing the slides actually.
Okay.
Okay. Why the ACL reconstruction fail? So ACL reconstruction fails. First of all, we have to know that what is the definition of ACL reconstruction failure. When objective laxity or patient's perception of instability develops in previously reconstructed ACL reconstructed knee. This is the general clinical definition of ACL failure. And when it comes about the database definition, it comes to complete graft tear with greater than 6 mm of anterior tibial displacement or translation as compared to the healthy knee. A positive pivot shift graded +2/+3 compared to the healthy knee. If you are getting all these things, then
Dr. Gaurav, your slide is not progressing. So we go to slideshow.
Yes, sir. It will progress. I'll be changing the slide actually.
Yeah, but you have gone to the second slide. It's still not coming on the screen.
Okay. You are getting first slide only, na?
Yeah, title slide. Yes.
Okay, 1 minute. Slides. Now are you getting? Hello?
No.
You click the current slide, slideshow from current slide.
I am
Yeah.
in slide, so
Yeah,
from current slide.
yeah.
Okay. Now are you getting?
Click it again. It's not coming.
Click it again.
From current slide. Are you getting?
No, it's coming, but it's in the PPT format. So you can go down and try to do that. Slideshow logo is there, no? There sign.
In the up and it
From the
in
beginning.
the left.
From the beginning, you try slideshow from the beginning. Yeah.
From beginning. It's from beginning.
Okay.
Are you getting?
Yeah, I think so.
If you just unshare and share it again, maybe it will work. Because
Okay. Stop sharing. Now I am sharing again. Psychological failure. Sometime you get patients, everything is well, even there is no instability, but patients will keep on complaining that there is some problem with me, some problem with me. So you can't have too much to do in those cases. So the non-anatomical tunnel placement is single most common cause of failure of this ACL reconstruction, especially in femoral side, but tibial side also there. So non-anatomical tunnel placement is most important and most debatable topic and topic to be learned. Everything it depends upon here only. Actually, ACL is all about tunnel placement only. You have to place the tunnel properly. Improper positioning of femoral tunnel is most frequent cause of ACL failures. Abnormal placement produces abnormal strength and length in the graft. If you put it, the tunnel should be at abnormal position. If tunnel is at abnormal position, it put a lot of stress on the graft, and with due course of time, sometimes it traumatize, sometimes it will get lax, sometimes it get lengthened, and ultimately you don't get the good result as expected. So you can see I have just this is simple clinical simple demonstration about how the tunnel placement failure occur. Why do the most of us we are doing ACL reconstruction mostly theoretically where are the placement points and all these things. I am just telling about how we get some difficulty and some bad tunnel placement actually. It is the anterior femoral tunnel. This is most common problem what we are doing. Tunnel should be posterior and inferior. Anterior femoral tunnel placement is very common and one of the frequent causes of failure of femoral tunnel. You can see we always discuss on this topic actually, even the concept of residencies and all these things, the AMR and different devices are there so that you cannot go to the femoral tunnel anteriorly. You can see here that this one how anterior it is. It is just behind the patella. Its ideal position should be the position here at near the Blumenset line, and this is the ideal position of femoral tunnel. But it is how an anterior tunnel it is. In this, you can see this is just behind the patella or maybe in patella. This is the problem of anterior tibial tunnel. You can see posterior femoral tunnel. This you can see this tunnel is here. This is posterior. This is the endobutton placement. You can see this is so posteriorly even there. The normal position should be here. So the you can find here the post-operative X-ray we are judging that this is the improper position of tunnel and most probably it is going to fail. So just when come to the for the tibial tunnel, you can see the tibial tunnel is so posterior here. Tibial tunnel lies for anterior 1/3 and posterior 2/3 junction. The tibial tunnel position should be here. This is the good position, but you can say this is so posterior. Sometimes this is so anterior. I have marked it because this is a bio interference screw. You can't perceive in image sometimes. That's why I have marked it. This is the position of tunnel. So it is so it is superficial. So it is superficial or it is that's why the tibial tunnel, oh, sorry, femoral tunnel or tibial tunnel, it should be matchable to the length. This is not like for your own easy-going surgery. Mostly, if you have graft 8 mm, you just drill for 9 mm and it passes easily. Go for struggle the graft through the tunnel. It will helping the patient, not the surgeon, but in long term, strength of the graft will be more. So the point of attachment is weakest link. I have already told the various options are available for fixation: interference screw, endobutton, loops, post, staples everywhere. But for femoral attachment, we mostly use suspensory fixation like endobutton, tight rope. Sometimes we use bi-interference screw. And in tibial tunnel, mostly interference screw is doing, but there are different techniques also like button or inside technique and all those things. But we are talking about the common things would you perceive. My motto of the paper is also that you should learn some common mistakes and common problem what we are facing and we are doing it. So the fillet fixation you can see the femoral tunnel. It is lying outside the bone. It should be flushed over the bone so that the strength of the graft should be good. This is not like that. This you can show the femoral endobutton is lying in the muscular substance. It is not good. Here you can show this is the graft of it. There will tunnel blowout. That's why femoral endobutton has launched so high up than the normal tunnel. You can see these pictures, and you can see that this graft is not going to suffice because the fixation is not enough. When the patient will bend his knee, the graft will be not stabilized. That's why this is like this. You can see the indicator fixation. Another example, the tunnel in tibia. It's superficial tunnel. It's not in the bone even actually. In this case, someone has this tibial placement is outside the bone, or you can see how superficial, or it is just tibial tunnel have eroded, or it's so superficial. You can see this is indicate fixation, and other you can see this one. The graft has endobutton not flushed. Uh, it has not been at the proper position. It should be here. It's here means it should be flush to the bone on the after the tunnel. It is lying inside the tunnel. That means either we have not pulled the endobutton. The surgeon had not pulled the endobutton out of the bone, or there may be tunnel breakdown and while cycling or while you are checking the strength of the graft, it came down. But the position is here. You can see the position is it lying inside the bone. So the fixation is not proper in the case. The chances of failure is high. Most likely this case is going to fail. So even this is the posterior tunnel. This is the site The size is posterior, tunnel is posterior, and inadequate fixation. Both is there. It is neither the position of tunnel is proper, not the fixation is adequate. Now, second one is graft impingement. This is the tunnel placement was most important. Why I have described earlier. Now, the second one is graft impingement. Graft impingement, if the graft is more thick or it is thicker than the notch, or sometimes it starts impinging. Start when you move your, when you means the patient is moving his knee, it starts impinging over the another compartment or at different places. There are different type of impingement, that is roof impingement or the anterior impingement. This is because of the graft impinges with the notch. Sometimes we always see after the procedure that whether graft is impinging or not. If graft has anterior impingement, you can go for notch plasty or something like that. So roof impingement, it goes where the graft is touching the notch of the femur when knee is extended. So it is mostly because of anterior tibial tunnel or anterior tibial tunnel placement. One of the major reason for this is. Another is anterior tibial translation because of posterior capsular thickening or anterior knee laxity. If knee become lax or capsule become thick, it pushes the graft to the anterior side and it started impinging. And impingement will cause pain and degeneration of the graft as well as degenerative arthritis in the joint. Graft will also break down in long term. The lateral impingement, lateral tibial tunnel placement is the major cause of lateral impingement. That's why most of the surgeons, when they are placing the tibial tunnel, they prefer slightly medial medial tibial tunnel in the in vivo studies actually. So it in lateral, if the tibial tunnel is slightly medial, it will not be there. Lateral impingement is common, and the posterior impingement because of medial tibial tunnel placement, or sometimes posterior medial is more important. In posterior impingement, ACL starts rubbing with PCL. With every movement, it starts rubbing with PCL. It is dangerous both for pain as well as it starts impinging, and it may lead to tear of PCL even. ACL is at risk. It's common. So the impingement is like this one. The impingement is another cause. This you can see other etiology are there inadequate notch plasty. If you feel that notch is impinging and you are doing notch plasty but you have not done adequately, then it will start impinging more. Variations of notch in shape. There are notch shape variations in every different people. You always have to think and you have to individualize and customize the ACL tibial tunnel placement in every knee. Apart from the size of the graft, if size is much more, you have quadruple. Sometimes people make six strand, it becomes 10, 11 graft and it starts impinging. Graft hypertrophy later on, sometimes we see the graft have become hypertrophy and osteophytes, the scarring, all those are etiology for graft impingement. Here you can see the anterior impingement. I have just seen a post-operative MRI. This is the ACL and it is impinging anterior. You can see this is the place where it is impinging. So the debridement, notch plasty, and revisions are the treatment options in these cases. So treatment is not is beyond the scope of this paper. I'm not discussing it. I have just mentioned it. So you can see the graft impingement, how it is impinging anteriorly. Apart from intrinsic graft failure, this is the part you cannot do anything. We don't know actually. Graft rupture success in 2% autogenous ACL reconstruction, up to 15% in allograft. We don't know why it is going to. It may be immunogenic reactions. The graft you are putting the there are some immunological reactions or something, but we don't have proper explanation. Till you can consider it as immunogenic reactions and the graft failure. So we are not discussing. I have already told I'm not discussing over this topic because you can't do anything here. About an infection. Infection is a common cause of failure. Infection actually you don't have anything to cause infection definitely, but you should go for proper hygiene, adequate antibiotics pre-operative as well as post-operative, and pre-soaking of antibiotics is very common and very important in this case. We have so many papers that if you pre-soak soak with antibiotic, the graft we are harvesting, the chance of infection are less. Better to be put in vancomycin if vancomycin is not there or somehow. You can go for gentamicin also, but vancomycin is good and and reliable antibiotic for soaking these grafts. Infection is another topic. Later, there is trauma. Significant trauma can cause excessive force on graft, leading to rupture during healing process as well as after full healing. Trauma can cause any time. Trauma is significant fracture. Trauma is very common, especially in athletes. They will come to you with re-rupture of grafts. So trauma is very common. Aggressive rehabilitation and early physical activity increases the risk of traumatic graft injury. We have so many papers. Actually, graft starts get incorporating and adequate fixation and vascularization after 6 weeks, and from 6 weeks to 12 weeks, very crucial period. But for knee stiffness, we start physiotherapy and rehabilitation in those periods also. If you don't have some good physiotherapist, or you are not monitoring the patients of your own, sometime aggressive rehabilitation and these aggressive physical activity increases the chances of early traumatic injury, traumatic graft failure, and people come with early failure of graft. They'll say, doctor, I was good for 2-3 months, and now I am getting instability again. And you'll check and you'll go for MRI, you'll get that graft is traumatized and it is rupturing. So these are very common, these are common thing which we perceive in day-to-day practice. These all X-ray and all the things are from my OPD, and people are coming for second look surgery or then this, and I have collected this and just I am telling all you about this. This is the trauma. This is all about this. The take-home message from my side is: think twice before drilling the bone. Drilling a bone is most important, and you should be going. There should be no hurry. There is no any no any uh, great thing that you are doing ACL in 20 minutes. Go for 1.5 hours, but go for a good ACL, because it's his life. The patient which you are drilling is drilling in his bone, not your bone or mine bone. So before drilling, you have to think twice. Proper tunnel position is the key to success. So tunnel position is the key to success, and it is the only thing you have in your hand for proper outcome. Graft thickness should be adequate. You have told in hamstring grafts you don't have these options, but if you are taking BTP grafts, under grafts, you can check that at least 8 mm. I think graft is okay, though in technically or in 10 mm graft is considered okay, but I think that 8 mm graft is in Indian population is okay. People are happy and uh, having good knee. Avoid scopy and degenerated knee. Degenerated knee starts when you start scopy and degenerated knee, it will start later on degenerative trauma and secondary degenerative arthritis, and it will lead to patient will complain with pain. Even if your graft is good, patient will not be satisfied. That's what I am generally avoiding. Even I have learned where I have trained where all the places they are avoiding in degenerative. Meniscectomy and meniscal repair. In cases of associated meniscal tears should be more planned. Meniscectomy or inadequate meniscal repair is very common cause of ACL failure. When you are going for ACL reconstruction and you're finding that the meniscus is tear, go for repair if possible. It is very important. Not or later on patient will come with complaint of pain or something like that. You will tell that they have to go for second look surgery, and it's a very common cause of secondary failure. So meniscectomy, and it is very commonly associated with ACL injury. So meniscectomy, it's very important. If you are going for meniscectomy or meniscal repair, you should be more precautious and more oriented. Secure adequate fixation. Adequate fixation is very important. I have already described so much. So secure it, and it is very skillful. You can people are using different marker pen, or sometimes they use Vicryl for the marks, or they are using Siam for this positioning. So do whatever you want, but adequate fixation is the key. Hygiene should be maintained. OT operation theater and all these things should be proper. Aggressive rehabilitation should be guarded. Either you have good physiotherapy or you should monitor yourself. So you cannot lie over the patient's knowledge. Intraoperative X-ray is adjunct to good surgery. Most of people are using it. Even I am using in many cases. I'll also suggest that intraoperative X-ray it take hardly 2-3 minutes. Go for an X-ray view. and you will be satisfied. And post-operative X-ray is must. Post-operative X-ray before closure, you should go for post-operative X-ray in the theater. That if you have any problem, you can change at this place actually. So these are the message, the most what I want to say and call it about. And in this COVID time, thank you for the listening, and stay home, stay safe, and thank you so much.
Thanks, Dr. Kumar. There are a few questions like how do you identify the ideal position intraoperatively? So whenever you are doing a scopy, so what is your take for the ideal position of femoral tunnel and ideal position for tibial tunnel?
Nowadays actually we are doing anatomical reconstruction. You will most of the time you will find there are remnants of ACL, and I go through it. Apart from it, you have many options. There are so many. It's for proper femoral tunnel positioning is different thing, and it requires a lot of time to describe. But in nutshell, what I can tell, if you have remnants of ACL footprints, go in the center of ACL footprint. It will always give you a good fixation. Apart from it, if you can go for, there are different theory, the resident ridge theory, there are this so many other thing that it will below 2/3 from the blooming sight line below it, and 33% from above it.
So what will
These
be
all
the
are.
position for your femoral tunnel?
Yes, sir, please.
What will be the position of the limb for when you are preparing a femoral tunnel?
It is a 110-degree inflection I generally prefer to go for.
So how can you intraoperatively avoid these complications like the endo button going beyond the IT band or
Yeah.
incomplete? How do you identify that?
Yes, that is important. That's why I told you that while pressing the endo button, go for X-ray. There is CM in very short. You can check for CM, and if you are not comfortable, yeah, or not want to use CM, you can use markers there in the graft. Markers are very useful. You can just measure the tunnel, mark the point with some sketch, or if you don't want a sketch, just go for a one round wickerel there, and it will give you a good idea about the tunnel.
So
Sometimes
what is your choice of fixation? You use adjustable loop or fixed loop?
I mostly use fixed loop. Most of the time I use fixed loop there, but depends upon the patients and choices. But sometimes people, so
Running out of time. So very
yeah.
nice. Thanks for the questions. Sir Vassan sir, can you meanwhile share your screen, sir?
Yeah.
Thank you.
So meanwhile, Gaurav,
Yes.
so we have seen that, okay, I think so sir is starting, so let him do this.
Okay. Can you see the screen now?
Yes sir, please
Yes,
sir.
Good evening, everyone. Thank Dr. Prahalad for asking me to do this presentation, and also thank Biotek for the invitation. Um, so I'm just going to expand on Dr. Gaurav's talk. Actually, I mean, this is one of, I mean, he is talking about graft failure. So there is one thing which is in our hands. That is the anterolateral ligament, which we can do to prevent graft rupture in specific group of patients, not on all of them. So anterolateral ligament is not something new. We know about this for quite a long time. We've all seen this X-ray, which we call as a segment fracture, which indicates there is an ACL injury. This was described in 1979, where Paul Segond described as a fibrous early resistant band on the lateral aspect of the knee, which with external rotation undergoes a degree of extreme tension. And various other people have also described this structure on the anterolateral side. Houston, Terry, Irvine, and Vera, Vincent. I mean, all these years, I mean, they've been describing there is something on the lateral side. But the person who brought everything into attention was Stephen Claes in 2013. Before I go on to describe about this anterolateral ligament, I want to tell you about the complex structure which is there on the lateral side, that is the iliotibial tract. The iliotibial tract of clinical morphological significance was described by Kaplan in 1958. He described numerous layers and attachment, and he described the Kaplan fibers, which are the deep fibers which come from the iliotibial tract and attaches to the lateral intramuscular septum and the femur. These are called as the Kaplan fibers. And Godin, in the year 2017, he described in detail about the distal IT band. And he found two distinct fibers of Kaplan. One is the proximal Kaplan fiber, which is coming from the underside of the superficial ITB to the distal femur in a transverse manner. And another one is which runs in an oblique manner. That's a distal bundle. So going on to the Clay's paper in 2013, he described anatomical. We dissected about 40 knees and found a distinct structure in about 40 out of 41 knees dissected. And he checked knee at 60 degrees of internal rotation, which reveals some taut fibers, and described this as the anterolateral ligament. The femoral origin he described was lateral epicondylar region, proximal and posterior to the insertion of the popliteus tendon. And tibial insertion was in the midpoint between the Gerdy's tubercle and the fibular head. So further on, after this, he, along with Michael Kennedy, again described this anterolateral ligament, and this time they identified this in all specimens. The tibial attachment was the same. I mean, there is no controversy about the tibial attachment, but the femoral attachment, they said it's, revised is the proximal attachment is to be the slightly proximal and posterior to the LCL attachment. Various other people have also described this anterolateral complex. Freddie Fu, along with his colleagues, he described, he also did some anatomical dissection and found Kaplan fibers in 100% of the specimen. And he found a capsulo-osseous layer which inserts into the tubercle midway between the Gerdy's and fibular head. And the femoral attachment continues to the lateral end of the gastrocnemius. He didn't find any specific lateral ligament, but they said there is something there on the lateral side, and they described it as an anterolateral complex rather than a specific ligament. They said it's called as an anterolateral complex. So why this? Why do you want to check about this anterolateral ligament? So we all gone through this open ACL ligament reconstruction. Then it became arthroscopic, transtibial, and anatomical single and anatomical AL. So I've been practicing for the last more than 15 years, and I've done all these actually. So what is the problem with ACL reconstruction? So any procedure, there is a failure rate. So what's the failure rate of ACL reconstruction? The various studies show that it varies from 4% at 2 years to 30% at 15 years. So these are some of the studies highlighting the failures, both not only hamstring, it's with bone capsular tendon group as well. So it varies from 10, 12, 11. So these are all, some of them are 3 years, some of them are 5 years follow-up. So other thing to worry about is the pivot shift after doing an anatomically placed anterior cruciate reconstruction. So if you're looking at a ligament, we are looking at putting an ACL inside in the center, and people are wondering how a centrally attached ligament can prevent rotation. So just doing conventional ACL reconstruction would lead to normal AP laxity, whereas tibial rotational behavior remains relatively uncontrolled. So they found a positive pivot shift, and in this study, they followed the patient for 5 to 9 years. And if you have a positive pivot shift following an ACL reconstruction, the incidence of getting osteoarthritis is more. So several others are pointed out. There is other areas which can cause reason for ACL failure. We all know that meniscus plays an important part, and along with the anterolateral structure, these also are important secondary stabilizers in an ACL injury. So this people started to do this ALL reconstruction. Various people have described these. There is no argument about the tibial attachment. Most of them agree that the tibial attachment is midway between Gerdy's tubercle and fibular head. But the femoral attachment varies. People have putting it 4 millimeter behind, 8 millimeter behind, 3 millimeter behind. So there is no specific criteria of putting where the femoral attachment of the ALL. So apart from doing ALL, there is other reconstruction is doing a lateral extraarticular tenodesis. Tenodesis is not something new, which has been going on for, even before ACL reconstruction, people were doing ACL, this lateral extraarticular tenodesis for this rotatory subluxation. Various procedures have been described. Lucy, Ellison, and Andrew, and McIntosh, and Lemaire procedure, which is original Lemaire procedure. They took a strip of this IT band. They put 2 tunnels. One tunnel just began the attachment of the lateral to the gastrocnemius, and coming behind again and bring it back again, reattached to the Gerdy's tubercle. So people have modified this Lemaire, and I'll talk to you about that. So a little bit about the biomechanics. I know it's a little bit of a boring topic, but we need to know why we want to do this ALL or extraarticular tenodesis. So these chaps, Christopher Kittle did a study with cadaveric knees on a freedom robot, and they found, if you do ACL, if you cut the ACL, it's the main restraint for anterior translation. But when it comes to rotation, they found that the superficial and deep layers of IT band were the primary restraint for tibial internal rotation between 30 and 90 degrees of flexion. And they found ALL also contributes, but not as major as the IT band. And Interhog et al., they did a cadaveric study using the freedom robot. They did, they stimulated the ACL tear, ACL reconstruction, modified McIntosh, modified Lemaire deep, and modified Lemaire superficial, and tension the knees at 20 newtons and 40 newtons. Lemaire superficial is superficial to the LCL, and they put deep to the LCL. It's deep. So they found that the anterior drawers and pivot shift is restored after ACL, but never come to the normal knee. So this is the normal knee, and they found that even if you do ACL deconstruction, it never comes to the normal knee. This is the anterior drawer, and this is the pivot shift. And ALL reconstruction, if you do it, again there is there is a persistent anterior translation and persisting internal rotation, similar to the ACL reconstruction. But if you do McIntosh or deep Lemaire, it approached normal knee. So if you get, this is now normal knee, and these two are the McIntosh and the deep modified Lemaire approached near normal. If you put it superficial, Lemaire actually over-constrained the knee, especially in the 40 newtons pressure. So you have to, they said, there's always a worry about if you're putting a lateral ligament, the over-constraint. So what does over constraint does? What over constraint can lead to osteoarthritis. That is the worry about putting. I mean, if you put the ligament tightly on the lateral side. So, what are some of the results of ALL? And the Santi group in France, they've been doing this for quite a long time, and they've done this study. They did an ALL hamstring tendon. They compared with normal ACLR along with combined with ALL. Then they found the graft re-rupture rate is decreased. I mean, if it is with 8%, which is with just ACLR, and if you combine with hamstring, it's reduces by almost half. So this what is the results following LET? There are a few papers out by which compares with ACLR with lateral extraarticular tenodesis, and this Vadala et al. They found. I mean, if you do a Macintosh, they didn't do a Lamar, that did a Macintosh, and they looked at the pivot shift, which reduces by about, I mean, residual pivot shift was seen in 57% in Group A, and Group B reduced to 18.6. So Andy Williams from UK, he did a study began doing comparing with ACLR along with ACL plus modified Lamar, and they found that it reduced the residual pivot shift if you do a tenodesis. So this is modified Lamar where we take 10 millimeter strip of IT band, and graft is taken behind the ACL, and either you put a staple or a suture anchor, and then excess graft is switched back together. I'll show you a video again. So this, I mean, there's a lot of confusion going on about this anterolateral ligament. So 36 international researchers met in London in October 2017, chaired by Alan Goodgood and Charlie Brown. And they came out with these conclusions that ALL, there is a structure within the anterolateral complex, and superficial to deep, there are structures like superficial IT band, deep IT band, plant fibers, and ALL and capsule. It's a capsular layer in the Seebacker layer 3, and it various the morphology varies between individuals, and attachment is, as I described before, posterior and proximal to the lateral femoral epicondyle, and in between the Gerdy's tubercle and fibular head. There is an attachment to the lateral meniscus as well. And Segon fracture, they couldn't really point it down to ALL alone. There are some other fibers might be involved with the Segon fracture. And the primary stabilizer for anterior translation and internal rotation near extension is the ACL. Secondary passive stabilizers include ITB, lateral meniscus, and ALL. And so they were looking at the over constraint, which I was talking about, but they couldn't find any much evidence of over constraint leading to arthritis. But we have to be cautious about that. And they said there's 4 indications for doing an ALL. And patients who undergoing revision ACL, high-grade pivot shift, generalized ligament laxity and generic curvatum, and young patients returning to pivoting activities. So they did a randomized control trial. This is a stability study which was started in January 2014 across 9 centers across Canada and Europe. There were 300 patients in each arm, and this was published recently in last year, 2020, in the Journal of American Sports Medicine by Alan Goodgood et al. And they found that they looked at the graft failure and also the pivot shift. These are all high, these patients which were all done with, are all sport persons or who have a very lax knee, so high grade pivot shift. So these are all selective group of high risk patients. And they did ACL only, and graft failure was 11%. And when they combined with the LET, they found the rupture rate reduced to 4%. And the asymmetric pivot shift also reduced from 40% to 25%. So they came to conclusion the addition of LET to a single bundle hamstring tendon autograft in young patient at high risk of failure results in a statistically significant, clinically relevant reduction in graft rupture and persistent rotator laxity at 2 years of surgery. So this is only 2-year result. So just showing a video of one of my modified lamar procedure. This patient, as you can see, has got very dramatic grade 3 laxity. So, after doing the ACL, I have put the femoral graft in, but I've not tightened the tibial side yet. So, so incision along the Gerdy's tubercle, about 8 to 10 centimeter incision. So you take 1 centimeter width of graft. Length is about 8 to 9 centimeter. So you cut the graft and then you isolate the LCL. So you want to put the graft behind the LCL to put a stitch around the graft to pull it around. So pull it behind the LCL. Then you go behind the LCL attachment or the lateral epicondyle. So it's posterior and proximal to the LCL attachment. So you just roughen the bone there. I'm using a suture anchor here. You can use a staple also, and then but the stability group they said to in that position you should tighten the ligament. The anterolateral ligament champs, some of them do tighten the ligament at 0 degrees and some of them at 30 degrees. So you tighten the graft there, and you just remaining graft you suture it to the IT band itself. So after doing this, I have not tightened the ACL. I mean, put the ACL tibial screw yet. So I'll show you the pivot shift after just tightening the the lateral extraarticular tenodesis. So this is a pivot shift after the tenodesis. I've not done the tibial screw yet. So there is a dramatic reduction in the pivot shift. ACL, the ligaments have to tighten put the tibial screw. So thank you.
Thank you, sir. It was a very good illustration and very good evidence for ALL. So there is a question for you, sir. Like, if you want in a high-grade pivot shift, whether you want to do an ALL reconstruction or you want to do this lateral extraarticular tenodesis?
Well, in India, the problem is, I think, the cost, isn't it? So whatever, we still don't have evidence whether the ALL reconstruction or tenodesis is better. Studies have not been done comparing these two. So some form of ALL or extra tenodesis does work. So, if you put an ALL graft, then you have to put 2 tunnels. Either use a gracilis, just use semitendinosis for your ACL, and then use a gracilis tendon. But the problem is you spend another 20,000 rupees in putting a bioscrew for a tibial and femoral tunnel. And if you just do a tenodesis, you can still use the gracilis graft.
Yeah.
So the cost is very less.
Sir, what will be your indication for ALL, sir? Like extra tenodesis.
So this, the 4 indications. It's the same thing. If you have a grade 3 clunk and pivot shift, then yes, you have to probably, do it. Especially if the patients are sporty, definitely you have to do it. And revision cases and patient with ligament laxity and these are the indications.
Okay, sir. Then I think so. I will proceed with my topic now. Thank you, sir.
Thank you.
Yeah. So after seeing why an ACL fails, and so we will just see what is the role of primary ACL repair in our practice. So ACL repair is nothing new. It is being these are these have done an extensive research with regard to primary repair. So we all come across these ACL injuries in our day-to-day practice, and way back in 1895, Vassan has first described the ACL repair. So ACL repair was gold standard treatment in 1970s and 80s before they realized that it had a lot of failures and started doing reconstruction. So we know anatomy, it is a very small ligament which has anteromedial and anterolateral bundles, and we have done an extensive research and studied its biomechanical aspects, and we also know how it looks on the arthroscopic anatomy. So it is very important to know the anatomy so that you will be able to realize the tears and decide whether you can repair them or have to reconstruct them. So we all have been taught that ACL is a very small intraarticular structure and it never heals because it is bathed in the synovial fluid, and since the knee is continuously subjected to movement, the formation of a stable fibrin clot is not possible, and definitely the ACL will not heal. And that is why ACL reconstruction is a gold standard treatment. So we will try to learn again here that all ACL tears don't heal, but there are few tears which definitely heal. So we have seen in the history that why the ACL had failed, because they were done in 1970s and 80s. So they were basically the open procedures. The surgical technique were not very advanced, and also they had no pre-operative idea about the tear location and morphology. So that is the reason they could not have done an excellent. They had a lot of failures. So also their rehab protocols were not very good. So now we have got advanced MRI, which before surgery we are able to understand the tear morphology, tear location, and we also have a very good understanding of the biology and various augmentation techniques which can help your ACL to heal. So the advanced arthroscopic techniques have definitely made this procedure a very successful procedure, along with the excellent rehab protocols. So preserving the native tissue which has excellent proprioception will definitely give good pain relief and excellent range of movement. So Sherman has given an excellent classification of ACL tears. The type 1 or the proximal avulsion tears, type 2 or where still 75 to 90% of the distal ligament is intact. Type 3 and 4 are where type 3 is where 25 to 75% of distal ligament is intact, and type 4 are hardly 10 to 25% of distal ligament is intact. So type 3 and type 4 are the basically mid-substance tear, which are not the ideal candidate to be repaired. Then there is also a modified type 5 where the tibial avulsion from the avulsion of the ACL from the tibial side. So these are the various graft options which we commonly use for doing the ACL reconstruction. So if you have an ideal candidate for repair, so definitely we should give an opportunity for repair so that we can avoid this graft morbidity. So there are several techniques which are being described in the literature. The dynamic intra-ligamentary stabilization. This is a bridge enhanced ACL repair technique. This is the most commonly done internal bracing technique. And then we have suture anchor technique. The technique 3rd and 4th are the one which are most commonly used techniques. and they are very much reproducible techniques. So again, the same group of authors have shown that whenever these stairs are have an intact synovium, so they have shown that they have an excellent outcome. And the tears which are multifragmentary and tethered, so they have, even though if they are avulsed, they have little guarded outcome. So even they have done a research where they have transposed the fat pad which is present over the PCL after repairing to enhance the biological healing. So what are the advantages of this procedure? It is a relatively short procedure, minimal invasive. There is no morbidity following graft harvesting. And also suture augmentation can be done without making a big tunnels. You can do it by making a very small tunnels. And also it is a very good technique in pediatric injuries where you can still spare the physis. So the recovery is fast, and it preserves the proprioception and native kinematics. But only disadvantage is you should have a proper selection of the patient, and still the long-term results are awaited in the literature. So this is the simple technique where and then fix it over the femoral side, and also they do an additional reinforcement, that is internal bracing using a suture tape. So this is our technique, what we do, the similar technique. This is a type 1 Sherman's tear. So we took a couple of lasso, one in the anteromedial bundle and then another in a posterolateral bundle. So after doing this, we made a tunnel, small tunnel on the femoral side. So you can see that the graft gets well stable. So this is at the follow-up. This patient is having excellent stability. So you can fix this by suture anchor or by a endovitrum. This is another interesting case. Patient presented with a grade 1 open femur fracture. If you see his knee, there is avulsion of the fibular head. So we did an MRI for this patient. He had an avulsion of PCL from the femoral side, tibial avulsion of ACL. So we fixed the femur, and then we saw this patient was having gross instability. So both anteroposterior instability and also a varus instability. So we decided to do an arthroscopic procedure for him. So we were able to see that there is an avulsion of the femoral side PCL there, and this is tibial side ACL. So we did a similar procedure. We took a couple of lassos, then we fixed it like an ACL avulsion fracture over a bony bridge, and then we did fixation of the femoral side PCL similarly by taking a couple of lasso sutures with knee scorpion and drilled it over a femoral anatomical insertion. So initially we tried using a suture anchor, but if you don't use a passport cannula, you can have a suture issues. So we had a stable fixation. So this was the immediate post-op stability which was seen after this procedure. So this is a patient at 3 months follow-up, and now his fracture is healing well and he is having an excellent outcome. So this is similar patient, tibia fracture, also had an femoral tibial PCL avulsion injury. So after fixing the tibia, we were able to identify gross anteroposterior instability. So we decided to do a scopy for him. So he had a similar pattern of injury. Here the ACL was avulsed from the tibial side, and PCL was avulsed again from the tibial side with the bony chunk. So we did a similar procedure for him, and taking a couple of lassos here on the ACL and also on the PCL. So we fixed both ACL over the bony bridge and PCL over a endo button, and this was the stability at the end. So it was an excellent stability we achieved following this repair. So this is the immediate post-operative stability. So this was the stability, and this patient is also doing very good. So these are patients subjected to our routine rehab protocol. We immobilize them in a long knee brace for 4 weeks and allow isometric exercises and intermittent range of movement exercises. Then we allow them partial weight bearing with a hinge knee brace, and after 8 weeks we do an aggressive quadriceps strengthening exercises. So these are certain articles which have shown that primary repair has a good outcome. So this is there are several articles who have come across the incidence of ligamentous knee injuries with ipsilateral long bone fractures. So we should always have an high index of suspicion when you are treating these kind of injuries. As being a trauma surgeon, you should not miss the knee injuries in these long bone, and doing an appropriate repair or reconstruction, you can have a satisfactory outcome. So this is again similarly multiligamentous knee injury. If you able to identify on the MRI, and you can select your patient and do a primary ligament repair. So these patients do have an excellent outcome. So where are we today? So we know that ACL tears do heal, particularly the proximal tears, which have a good volume of stump left over, has a promising outcome. The advanced MRI, the arthroscopic techniques, better understanding of the biology has been the great boon for this technique. Even if your primary ACL repair fails, it will be a simple technique. It will be a primary ACL reconstruction will solve the problem. So definitely, there is a place for this procedure in my armamentarium if I have an optimal patient candidate for the repair. Thank you. Sir, shall I proceed with the next topic, sir? Before at the end, shall I take the questions? Shall I go through the? Yeah. Okay. So I'll just, we had Dr. Yogesh who could not attend this. So I'll just, for the completion, I will go through the avulsion fracture fixation video. So we all know the anatomy of the ACL. So this picture gives a very good illustration of the ACL and the structures surrounding it. So whenever there is an avulsion of ACL, so it may be associated with an anterior horn of medial and lateral meniscus injury can also be associated. And if you see this intertransverse ligament, this will be the culprit for the ACL displaced avulsion fracture to get reduced properly. So sometimes you will have to knock it off to get a satisfactory reduction. Most of the time it is an hyperextension injury which produces these injuries, and most often they are seen in immature skeleton in pediatric age group. And Mejia's and McKeever's classification is a well-known classification. Type 1 undisplaced. Type 2 is partially displaced with intact posterior hinge. Type 3A is completely separated, displaced, whereas type 3B is with rotation, and type 4 is with comminution. So most of these patients present with painful knee and with hemarthrosis. So sometimes the PCL injury patient will not have much hemarthrosis and can miss these injuries. So assessing clinical stability in acute scenario will be very difficult. So you have to aspirate, have to give some time and then do an assessment. Investigations are very helpful. You can identify the bony avulsions on the X-ray, and then further CT and MRI will give you much idea about the kind of tear and also the associated injuries. So this is the protocol we follow. Type 1 and 2 can be treated conservatively in POP in extension. So few authors have mentioned about hyperextension, but hyperextension is very painful and sometimes may cause neurovascular problems. So immobilizing in mild extension is sufficient. So whereas the type 3 is and 4 are the one which definitely get benefited from the arthroscopic fixation. So there are various ways you can do this fixation. You can use screws, you can use staples, you can use suture twist technique, which we routinely do now. These were our initial cases where we used to use screws, and these are biomechanically less stable construct, and also they can produce chondral injuries if your screw head is not buried properly, and you may need another procedure to remove the screws. So this is the suture bridge technique. It is a very simple technique, a very reproducible technique, and also useful in the pediatric age group with open physis. So you can do a transepiphyseal fixation. So we'll see the videos of this technique. So I'll go through these steps while running the video. So this is a case example. So this is an avulsion of anterior tibial spine. So we are preparing the bed. So you can see the anterior intertransverse intermeniscal ligament, which is the culprit, which prevents the reduction of this fragment. So you will have to take out that, and then you temporarily fix it with a K-wire. Then you throw a couple of lasso by using a knee scorpion in both anteromedial and posterolateral bundle each. And here what we do is we just make a small tunnel by using a 2 mm K-wire or a bead pin, and use some technique to shuttle the sutures. So this is all inside out meniscal needle which we used to use, or you can even use a simple spinal needle to shuttle the sutures on the bony bridge. We make two small tunnels on the anteromedial aspect of the tibia. We crisscross the sutures so that it presses the fragment on the bone. So this is the stability you get after fixing it on the bony bridge. So this is another case example. If you see here, it is a type 4 avulsion fracture. It is also associated with root avulsion, and there is not much of bone here. There is very minimal bone on the ACL. So these are the candidates where if you put a screw, it will definitely not be of much importance. So you better do a suture bridge technique in these kind of avulsion fractures. So we do a similar procedure here. Again, take a couple of lasso sutures, then make the tunnels on either side of the crater, and also suture it over either an endo button or the bony bridge if you have. So then they give a very good outcome. So we have seen all these patients having a very satisfactory outcomes in our practice. So this is another case example. Why I am showing is they all are different cases, so different types. So again, if you see a lot of comminution in the fragment, and again much less bone is seen here. So this patient also had associated root tear, which we also repaired it separately. So the importance here is, again, you take on either side of the crater, you crisscross the lassos, and you see that your repair is excellent. The ACL gets out. So this is the literature which supports this 3-point fixation technique. There is another article where they have made 4 tunnels, which we do only 2 tunnel technique. We don't use this 4 tunnel technique. So the take-home message: the type 1 anterior tibial spine fractures can be treated conservatively. Type 2, it's a border gray zone. You can try conservatively. If still it is displaced and has instability, better to do arthroscopic fixation. Type 3 and 4 definitely needs arthroscopic fixation. Suture BIS technique is mechanically sound, and it is a reproducible technique, and less of hardware, can be even done in the pediatric with open physis, and also you can address the associated injuries at the same time. Thank you. Stay safe, stay fit.
It's a good presentation, Dr. Prahalad. There are a few questions I think for you. So first question is, what is the chance of developing cyclops post ACL repair?
Yeah, there is cyclops possibility is there, sir. What we have seen is the patient may have little bit of anterior knee pain because of the prominence of the bones, rather than ACL cyclops. If you don't, they have a good stability, but sometimes particularly in the type 4 where you have multiple fragmented bony pieces, so you can see that some bony prominence will be there. So it is better you do a proper shaving off of the prominent structures after doing your repair.
Okay, thank you. Next question is, what is the maximum time limit to consider for primary repair? How late can we do ACL repair?
3 weeks. So what the literature have says is up to 3 weeks, it is still a good chance of doing repair. But I have done a repair in 6 weeks where we did an additional micro fracture kind of thing in the notch. So to enhance the healing of that ligament, we are following up that case. It is 6 months now. So far, so good. So ideally, in the literature, they say up to 3 weeks.
And how early can you do this?
Have much of bone bruise and all, so I don't think so. It is not a reconstructive procedure, so we are not going to make any big tunnels and all. So we have done all our cases as early as possible. So we don't have to really wait for the marrow to settle down or something like that, because we are not going to use any graft here. So we can take it as early as possible.
Yeah, the problem doing early ACL reconstruction is arthroplasty.
Yes.
So I think if you just do a repair, there's not much fibrosis.
The one thing is the patient selection, sir. So you have to avoid type 3 and type 4 Sherman's tear, because they are the one which will never heal and you will not have a satisfactory outcome. But type 1, type 2 and type 5 tears are definitely a good candidate if you have a good ACL stump. And also about age, people are told that there is no any such thing that you should do it in a young, so you can do it in all the age group. And doing an additional microfracture or marrow stimulation is another thing they have suggested to enhance the your fracture repair, healing of your repair.
Yeah, the other problem is ACL injury. I mean, you see the tear on the MRI, but nobody can judge what is the intrinsic nature of the ligament itself, because there are some studies which show there is some intrinsic damage to the tendon itself when there is an injury. So you have to be aware there is a large failure rate with ACL repair, and I am not aware of any RCTs been done for ACL repair yet. So we have to wait for the further studies on this.
There is one study, sir, which I have quoted. So they have, as you told, the multifragmentary ACL repair. Like suppose if they have a lot of comminution of the ACL, so they had a very poor prognosis. If the synovium over the ACL was still intact, and even they have seen that even after 6 weeks, where the proximal ACL stump has gone and stuck to the PCL, so they have released that and they have also repaired it, and they have transferred the fat pad of the PCL to enhance the healing. So as you told, patient selection is very important. The proximal tears or the distal tears have good prognosis. The mid-substance tear and the tears which are shattered, you better avoid doing the repair. Augmentation is again a good option. So you can do the augmentation to
internal brace.
Internal bracing.
Is there any other questions? So do you delay weight bearing after this technique?
We routinely allow non-weight bearing for 4 weeks, sir, and then gradual weight bearing after 4 weeks with a hinge knee brace, and maybe after 6 to 8 weeks we allow full weight bearing.
So it's different from ACL reconstruction.
Yeah. ACL reconstruction, you start doing partial weight bearing and full weight bearing.
Yeah. Other questions? I think we have answered all the questions.
So I think so. If all the questions are answered, sir, so shall we wrap up the session?
Yes.
Yeah, you're already, I think so, half an hour overshadowed.
Yeah.
So I thank all our faculty who had actively participated and come up with this webinar. I thank Biotek for coming up with this webinar. So we'll see hereafter a few more series of webinars. So thank you all. Thank you everyone.